Bismillah ar-Rahman ar-Rahim. A pleasure and great honor to have this webinar with two eminent professor speakers, scientists, Professor Osama Sanad, Professor of Cardiology, Banha University, and Professor Tamer Mustafa, Professor of Cardiology, Zagazig University. And of course, I'd like to thank Novar's company for their support in this project all over the country. As we know, the heart failure is a major syndrome, have a big burden on the hospital admission, on the economy, and on the lifestyle of the heart failure patients. As we know, the abbreviations of heart failure are dynamic process changing every few years. So we have now two big categories from the heart failure. That's called heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. Today, with my colleagues and my professors, my dear professors, will have two presentations. Dr. Tamer Mustafa will give us the recent advances in the treatment of heart failure with preserved ejection fraction, and we'll have some discussion and will review and answer the questions of the attendees. And then Professor Osama Sanad will give us the guidelines for hypertension with preserved ejection fraction. So we'll let them to show the presentation, and I hope this will be a good science, good learning for everybody. Thank you very much. Dr. Tamer, you can start your presentation.
Okay, thank you, Professor Hazem. It's an honor to me to be with Professor Hazem Khamis and Professor Osama Sanad in this night meeting about the heart failure with preserved ejection fraction. We will talk about HFpEF. Okay, HFpEF treatments. What are the treatments that are working, and what are the treatments that are not working? Will be our start with HFpEF treatments today. The drugs that are doesn't work in HFpEF or doesn't prove a success in the treatment of HFpEF, we will start with what about the sildenafil. Sildenafil has no support for the use in HFpEF. We have two trials. The first one showed the effect of phosphodiesterase 5 inhibition on exercise capacity and the clinical status in heart failure with preserved ejection fraction. And the second one shows the effects of sildenafil on invasive hemodynamics and exercise capacity in heart failure patient with preserved ejection fractions and pulmonary hypertension. Both trials failed to give a support to the use of sildenafil in heart failure with preserved ejection fraction. The second one is the use of isosorbate mononitrates in treatment of HFpEF. This is NIAT HFpEF trial. The NIAT is about to use the isosorbate mononitrate with the dose up titration starting from 30 milligram up to 120 milligram per day over 4 weeks. And they show, after evaluation of the 6-minute walk test, the quality of life, and the NT-proBNP, that no benefits of isosorbate mononitrate treatment in HFpEF, but there is a bad news for this drug with a suggestion of worsening of the activity levels. The third one is ivabradine. The IDEFY trial is for 170-90 patients with NIHA function class 2 and 3, patient in sinusitism with heart rate 70 beat or more. They have a pro-PNP more than 220 or PNP more than 80, and left ventricular ejection fraction of 45% or more. There are two groups of standard treatment, group with placebo and the group with ivabradine titrated up to 7.5 twice daily. And patients are followed up for 8 months. They are assessed for 3 co-primary endpoints. Number 1 is echo Doppler E/E' ratio. Number 2 is the distance on 6-minute walking test. And number 3 is the level of NT-proBNP concentration. No value for addition of ivabradine in this group of patients, as there is no improvement in any of the co-primary endpoints with ivabradine. So these are medications not working well, not give the support to use to prescribe in patients with HFpEF. What about the working drugs or the drugs that might work in this group of patients with HFpEF? First of all, we should know that the SPRINT trial shows that blood pressure lowering reduces the adverse outcome. For example, the heart failure hospitalization reduced by 38% in the SPRINT trial. And the elevated blood pressure from the HFpEF trial and the SPRINT trial is not a symptom, but still bad. So what about the group of SGL2 inhibitors that block SGL2 in the kidney and reduce glucose and sodium reabsorption? The effect based on this mechanism of action is the following: diuresis, natriuresis, reduction in hemoglobin A1c, weight loss, and systolic blood pressure reduction. So the potential mechanisms to use SGL2 for cardiorenal protection is that the improvement in the left ventricle loading conditions, so the diuresis, natriuresis, and afterload reduction, the improvement in myocardial energetics and the metabolism, the direct effects on the myocardium, and the tubuloglomerular feedback, and the reduction in the intraglomerular hypertension. All of these mechanisms can give cardiorenal protection of this group. So there are 2 trials done on heart failure with preserved ejection fraction to see the outcomes using the SGL2 inhibitors. The Emperor Preserved, which uses the empagliflozin outcome trial in patients with chronic HFpEF, and the Deliver study design, and both of them searching for primary endpoint of cardiovascular death, hospitalization for heart failure, and urgent heart failure visits. What about the use of interatrial shunt device? The interatrial septum defect proposed mode of action suggests a dynamic decompression of the overloaded left atrial chamber by shunting blood from the left atrium to the right atrium. By applying the device that close ASD, we see what about the change in the pulmonary capillary wedge pressure, which measured after 1 month from the baseline. The diagram in the right one shows that there is a reduction in the pulmonary capillary wedge pressure, which may be a potential mechanism to reduce the risk of heart failure in this group of patients. What about the exercise? The exercise shows systemic and cardiac specific effects. About the systemic effects of regular exercise on the skeletal muscles, it decreases the hypertrophy, hyperplasia, and the fiber type switching. On the vascular level, it increases the flow, vasoactivity, and angiogenesis. And on the metabolism, it improves the insulin sensitivity, increase the oxidation phosphorylation, and increase mitochondrial biogenesis. What about the cardiac effects of exercise? About the cardiac growth, it affects the hypertrophy and the hyperplasia. It gives cardioprotection through decreasing ischemic injury. It improves the cardiac function by increasing stroke volume, cardiac output, improve calcium handling, and the T-tubule organization. For metabolism, it improves the oxidation phosphorylation and the mitochondrial biogenesis. And vascular, it also increases flow, vasoactivity, and angiogenesis. So in AHA, defined the poor and the intermediate activity are associated with higher risk of heart failure hospitalization according to the top CAT trial. And this is a study for exercise training which improve exercise capacity and diastolic function in patients with heart failure with preserved ejection fraction or not. This is a small study, about 64 patients. 56 of them are female, age 65 plus minus 7 years, and 2-to-1 randomization. They give the usual care and 2 groups. group with supervised endurance or resistance training, and the group with only usual care. And they search for the endpoint, primarily the change in the peak VO2 after 3 months, and secondary, the effect on cardiac structure, diastolic function, and the quality of life, and all are improved with exercise. So exercise and diet improve peak VO2 and Kansas questionnaire in heart failure with preserved ejection fraction. On the left side, we see the percentage change in the peak VO2. That is the maximum can be given when applied to diet and exercise. And also the Kansas questionnaire overall score improved whether we apply diet only or diet and exercise. So the current treatment strategies, number one, are the risk factors optimally controlled? The blood pressure should be less than 130/80, especially using RAS inhibitors. Hemoglobin 1C should be controlled. Myocardial ischemia should be improved or reduced. The control of heart rate, especially under stress. AF, can we restore sinus rhythm or not? If there is signs of hypervolemia and dyspnea on exertion, we should apply diuretics. Weight reduction and regular exercise are lines of treatment for heart failure. So what are the future directions in this group of patients with HFpEF? First of all, the drugs on horizon targeting the nitric oxide cyclic GMP axis. There are vitality trial which show the first weight in worsening heart failure with preserved ejection fraction. Now they are in phase 2B. There's capacity HFpEF for paralytic weight in HFpEF in phase 2 and satellite for EZD 4831 in HFpEF in phase 2A. The systemic effects of SGC stimulators, they show potential benefit may be better captured in patient-reported outcomes. And the drugs also on the horizon targeting the mitochondrial energetics shows that fair HFpEF study ferric carboxymaltose in HFpEF in phase 3 now, and affirm AHF ferric carboxymaltose in heart failure hospitalization in phase 4 now. The secondary causes should be searched in patients with HFpEF, and this is very important issue. Patient with pure heart failure with preserved ejection fraction is different from heart failure with preserved ejection due to a secondary cause. And this is gray zone. To distinguish between these two groups is very important issue because the treatment of the secondary cause will be the key in the case. If you lose the key, you cannot control the case well. The patients with amyloidosis. Patisiran can be used in patients with amyloidosis. Patisiran decreases the mean left ventricular wall thickness. The global longitudinal strain improved. The NT-proBNP decreased, and the adverse cardiac outcomes compared with placebo are improved at month 18. Another cause in HCM, hypercardiomyopathy. Mavacamten can be used in HCM to decrease hypercardiomyopathy and may improve the condition of heart failure in this group as a secondary cause for heart failure with preserved ejection fraction. In transthyretin cardiomyopathy, tafamidis are going in a trial in the patients with transthyretin cardiomyopathy. There are 3 groups: tafamidis 20 milligram once daily, 80 milligram once daily, and placebo, and then extend the study for a longer time after that to see the effect of this drug in the group of transthyretin cardiomyopathy. What about the future of heart failure management with devices? There are 2 articles to show these effects. One article about impact of practice-based management of pulmonary artery pressures in 2,000 patients implanted with the CardioMEMS sensor. And the second article is about the transcatheter treatment of severe tricuspid regurgitation with EG-to-EG mitral clip technique. So the future in the HFpEF include two issues: diagnostic considerations and the therapeutic considerations. For diagnostic consideration, we should refine the distinction between heart failure from the mildly reduced ejection fraction, what is called mid-range ejection fraction. Secondly, the consideration of 6 specific ejection fraction cutoffs. And number 3 is primary or essential heart failure with preserved ejection fraction versus presence of secondary cause of heart failure preserved ejection syndrome. We should target the secondary cause to resolve the condition of heart failure in this type of group. The therapeutic considerations, there are promising drugs and device therapies on the horizon. Example, SGL2 inhibitors, SGC stimulator, MPO inhibitor, interatrial device. The cardiorenal effects, the quality of life, and the recurrent heart failure hospitalization equivalent increasingly recognized as important outcomes. Precision and the personalized approach may be needed in some individuals. And usually remember that prevention is the key. The drugs on horizons in the treatment of HFpEF, like Emperor Preserved, using empagliflozin in chronic HFpEF, this is in phase 3. The liver using dapagliflozin in chronic HFpEF. The Preserved HF using dapagliflozin in type 2 diabetes and HFpEF. The Parallax showing using L-ARNI in HFpEF, and the Spirit for using spironolactone in HFpEF. So, to take our home message today, HFpEF is a complex interplay between multiple pathophysiological and comorbid conditions. Managing of comorbidities reduces heart failure, as seen as in the hypertension trials. Several medications have been examined in heart failure with heterogeneous results. We are still looking to future trial to assess more accurately how to manage these patients. And thank you very much.
Thank you very much, Professor Tamer Mustafa, for this illustrative and elegant presentation about the treatment of heart failure with preserved ejection fraction. I think from this overview, it is a difficult task to be treated. I think heart failure with ejection fraction and the lifestyle modification, the exercise, I think it's very good demonstration for their role in treatment of heart failure with preserved ejection fraction. So we'll go to the guidelines with Professor Osama Sanad to what's called to finalize the statement for this subject, and then we will open the discussion about the two presentations. So Professor Osama Sanad can give us the guidelines for heart failure with ejection fraction. Dr. Osama.
معك إن شاء الله. خليني أشكر الدكتور أحمد شوقي اللي منظم الويفز دي، والنهارده آخر ويف، وإن شاء الله تكون يعني خاتمة جيدة. وأنا مبسوط قوي إن معايا أخويا حبيبي الدكتور حازم والدكتور تامر، وما اقدرش انسى دور ايكوم انها منظمه الميتنج ده، وتنظيم ممتاز يعني كعادتها. بس انا عايز قبل ما اقول الجايد لاين اطرح كم سؤال كده. احنا زمان ما كناش نسمع عن حاجه اسمها هارت فيلير ويز بريزيرفد او ريديوز، هو هارت فيلير وخلاص. ابتدينا نقول هارت فيلير لان في كلينيكال مانيفستيشن بتاعت هارت فيلير، ديسنيا وايفن اورثوبنيا باروديسما بتقتص البلمونري ايديما، وبالايكو اللي هو الجولد ستاندرد فور diagnosis of heart failure ejection fraction بيطلع اكتر من 50. من هنا ابتدى يطلع مصطلح heart failure with ejection fraction with preserved heart failure with preserved ejection fraction. ولكن هل هو هنا ejection fraction اكتر من 50؟ هل هنا في ديزيز في الميوكارد cannot eject blood. احنا عندنا في ليفل 50 عشان نقول هارت فيلر ولا لا، بس الهارت فيلر الديفينيشن بتاعه ده كلينيكال ديفينيشن، ده كلينيكال دايجنوستيك كونديشن. طيب وهو العيان اللي بياخد ده هل هيستجيب للانوتروبيك ولا مش هيستجيب للانوتروبيك؟ وايه الكاتيجوري؟ اب تل ناو زي ما قال الدكتور تامر، لا لسه في ديبيت وفي حاجات كتيره قوي في الباثوفيسيولوجي، وطالما ان الباثوفيسيولوجي ويل نوت نون كليرلي واكيوريتلي، بالتالي التريتمنت مش هيبقى ويل استابليشد له. ابتدت الدراسات تشوف هل في اتيولوجي واضح ولا فيش اتيولوجي واضح. فكان اول حاجه بنشوفها السترونج اسوسيشن. ايه هي الحاجات اللي ايوه طيب اتفضل. For that reason, as regards the pathophysiological mechanism will not known up till now, so the treatment is not clearly applied to this condition. However, as regards the pathophysiology, research for the associated condition to the heart failure with preserved ejection fraction. For that reason, as my dear colleague Dr. Tamer said, there is no stable treatment. However, what about the guidelines? First, let me to revise this slide. What means by heart failure with mid-range ejection fraction? It is a category of patient which can be in between heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. So heart failure with reduced ejection fraction can be improved to be a heart failure with mid-range, or heart failure with preserved ejection fraction can be deteriorated and be heart failure with mid-range ejection fraction. Ejection fraction in the first category with heart failure with ejection fraction is below 40, and that was preserved above 50, and in between 40 to 49 is that with mid-range ejection fraction. European Society of Cardiology guideline first is recommend that to screen patient with heart failure with preserved ejection fraction or heart failure with mid-range ejection fraction for both cardiovascular and non-cardiovascular comorbidity, which if present must be treated in the way to be safe and effective intervention to improve symptom well-being and prognosis. So here the screening for the associated condition which may be a cause in this category on this type of heart failure. Later on, diuretics. No other measures, only diuretic, are recommended in congested patient and not in non-congested patient with heart failure with preserved ejection fraction or heart failure with mid-range in order to alleviate symptom and sign. Mr. Chairman, ladies and gentlemen, from this slide, we notice that first, I must screen for cardiovascular and non-cardiovascular and then to treat them for improvement of symptom. Second, the only symptomatic recommended treatment is that heart failure is diuretic. However, up till now, no definite treatment has yet been shown convincingly to reduce morbidity or mortality in patients with heart failure with preserved ejection fraction. Second, again for European Society of Cardiology, what the effect of treatment on symptom? Second item was the effect of treatment on hospitalization, and third, effect of treatment on mortality. As regards the symptom, diuretic will usually improve symptom of congestion إذا كانت موجودة. Second, evidence that beta blocker and mineralocorticoid receptor antagonist improve symptom in this patient is lacking and no effect. Even there is no clear evidence or definite evidence for the improvement in symptom in this patient with ARBs or ACE. Apart or with exception, candesartan, which improves the clinical NEHA class in patient with heart failure with preserved ejection fraction. So up till now, guideline only diuretic which can improve symptom. However, beta blocker, mineralocorticoid, although it has a diuretic effect, ARBs or ACE has no definite clue for that. What is the effect of treatment on hospitalization in patient, two category of patient with sinus rhythm and patient with atrial fibrillation. In patient with sinus rhythm, there is some evidence that beta blocker, nebivolol, digoxin, spironolactone, and canazaline might reduce heart failure hospitalization. For patients with atrial fibrillation, beta blocker don't appear to be effective, and digoxin have not been studied, and the evidence support arms is lacking. So in atrial fibrillation, there is no way apart from to control either control rhythm or control rate of atrial fibrillation, as the guideline concluded. As regards the mortality, and the trial of ACE, ARBs, beta blocker, and mineralocorticoid receptor antagonists all have failed to reduce mortality in patients with either heart failure with reduced ejection fraction, with preserved ejection fraction, or with heart failure with mid-range ejection fraction. However, in elderly, for all group, heart failure with reduced ejection fraction and heart failure with preserved mid-range, nebivolol reduce the combined endpoint of death and cardiovascular hospitalization without significant interaction between the ejection fraction at baseline and after follow-up, which means that the reduction in mortality in patients elderly is not related to the improvement in ejection fraction, but may be related to the type of drug, nebivolol, beta blocker in this part. And in all three types of heart failure, whether reduced ejection fraction or preserved or mid-range. In regard the American Heart Association, American College of Cardiology guideline, don't differ briefly from the European Society of Cardiology guideline as stated. Systolic and diastolic blood pressure should be controlled according to the guideline of hypertension. Diuretic should be used for relief of symptom due to volume overload, which will settle and be mentioned in the European Society of Cardiology. As regards systolic and diastolic blood pressure, it is accompanied cardiovascular or non-cardiovascular comorbidity must be. This was reported from and again here. Coronary revascularization for coronary artery disease, angina, or still present, still chest pain, in spite of guideline-directed medical and treatment therapy, still features pain, still there is ischemia, active ischemia, so coronary revascularization, whether by interventions or surgery, must be done to alleviate the symptom of heart failure. Management of atrial fibrillation, according to the guideline, must be done. Use of beta-blocking agent, as inhibitor, ARBs hypertension, and hypertensive patient with preserved ejection fraction. So the only, and the diuretic is mentioned above. The only don't mention in treatment of hypertension in patient with heart failure with preserved ejection fraction is calcium channel blocker, which is not recommended. ARBs may be considered to decrease hospitalization, mainly candidate 10 and HFpEF. Routine use of nitrate and phosphodiesterase inhibitor can increase for increase the activity and quality of life is not recommended. Don't effective as Dr. Tamer mentioned the study of phosphodiesterase 5 inhibitor in case of HFpEF, which not improve the quality of life, but definitely in male improve the sexual function. However, in different type of with heart failure with reduced ejection fraction, phosphodiesterase inhibitor may improve quality of life. National supportment is not nutritional supportment is not recommended in HFpEF patients. And in conclusion, for the American guideline, A recommended therapy for HFpEF are directed at symptoms, especially comorbidity and risk factor that may worsen cardiovascular disease. Mechanism of HFpEF and HFrEF treat congestion with diuretic for both, treating the precipitating factor, coronary vascularization with valve surgery. For HFpEF, manage comorbidity, atrial fibrillation management, nearly the same. As regards the perpetuating mechanisms, here treatment of neuroendocrinal activation with ARBs or ACE and in the microvascular inflammation. European Society of Cardiology General Management of patients with HFpEF treat underlying etiology, ischemia and myocarditis, treat cardiovascular comorbidity, hypertension, diabetes, pulmonary hypertension, with RAS inhibition, treat non-cardiovascular morbidity, comorbidities like chronic kidney disease, iron deficiency, OBD, obesity, which is at the must in case of patient coming to complaints from dyspnea, orthopnea, and easy fatigability and lack of exercise capacity. Diuretic for symptom relief. It is the most important one. Screening for amyloidosis, as Dr. Tamer mentioned, and its treatment. Now, what about NICE guideline for HFpEF? Heart failure is HFpEF manage comorbidities such as hypertension, atrial fibrillation, ischemic heart disease, diabetes mellitus, align with NICE guideline. There is no difference, there is no specific line, specific recommendation for treatment of patients with heart failure with preserved ejection fraction and NICE guideline. But the management must follow the guideline for heart failure with reduced ejection fraction, apart from treatment of comorbidity, which if it is present in patient with heart failure with reduced ejection fraction, must be treated in the same time, side by side to anti-failure measures. What about Canadian cardiovascular heart failure guideline? Principal line in pharmacological management of HFpEF, first, identification and treatment of underlying etiological. هنا يمكن في برضه maybe some observation about etiological or associated factor implicating in the development of heart failure with preserved ejection fraction. There is no, up till now, there is no well-settled etiological factor for HFpEF. Identification treatment of comorbid conditions that might exacerbate the heart failure syndrome, control of symptoms, and realizations of clinical and meaningful cardiovascular endpoints such as heart failure, hospitalization, and mortality. And I suggest candidates can be considered to reduce heart failure, hospitalization in patients with HFpEF. Recommend the systolic and diastolic hypertension may be controlled as a Canadian hypertension program and guideline. Recommend the loop diuretic be used to control symptoms of congestion and peripheral edema. Suggest that in individuals with HFpEF, so potassium less than 5, estimated glomerular filtration rate more than 30, mineralocorticoid receptor antagonists like spironolactone should be considered with close observation of the serum potassium and creatinine level. Here, in comparison between the three categories as regard characterization, as regard outcome, and guideline-directed medical therapy. First, for age, for gender, for coronary artery disease. HFpEF as regard common in elderly patient and reduced ejection heart failure, heart failure with ejection fraction less common than heart failure with ejection fraction and age. So it is age related. It is possible to say that HFpEF is age related than HFrEF. As regard the gender, more common in male 6 heart failure with reduced ejection fraction, more common in male. As regard coronary artery disease, more common in patients with heart failure with reduced ejection fraction when compared to heart failure with preserved ejection fraction. And morbidity definite as regard morbidity and mortality for this two important category of heart failure. Morbidity more common in patients with heart failure with reduced ejection fraction, and mortality again more common in this category of patient. So what is stabilize conclusion that morbidity increase and mortality increase. Medical therapy is ARBs, ARNI, beta blocker, mineralocorticoid receptor antagonist. All can be used in patients with heart failure reduced ejection fraction. However, with preserved and mid-range ARBs, mainly candesartan, and mineralocorticoid, which decrease the hospitalization of 2EB, can be used in patients with HFpEF. And finally, in conclusion, heart failure with ejection fraction, and again, heart failure with mid-range ejection fraction is not uncommon. It has morbidity and mortality, which is not far less than that of heart failure with ejection fraction. It has multiple pathophysiologies and comorbidity, but up till now, the etiology is not settled. Diagnosis is not so simple and requires scoring system. Management includes comorbidity management with a few medication indicated in these scenarios. There are many trials pending for the management of this disease, and Dr. Tamer mentioned most of them. The guideline also addresses this disease entity. And now, thank you. We are waiting for the valuable discussion of my friends, Dr. Hazem.
دكتور سامح، لما الدكتور حازم يضم علينا، حضرتك شايف دلوقتي انه الدايستوليك هارت فيلير اصبح ترم ضايع في النص ما بين الريديوسد والبريزرفد والميد رينج، ولا
سوري تامر سامعني؟
انا سامع حضرتك، الحمد لله على السلامه يا فندم.
الله يخليك. ثانك يو دكتور اسامه بي، ثانك يو فيري ماتش فور ذيس برزنتيشن. تامر سامعيني؟ زي ما انا شايف كده ان الدياجنوزيس،
بس الفيديو مش باين.
هو قاعد في الجاردن بقى يا فندم، فالموضوع مختلف.
لا والله الصوره مش باينه دي من ايكون بقى.
باين.
انت الصوره باينه عندك يا تامر؟
انا شايف الدكتور حازم.
اوكي.
ولا انا مش باين ليه؟
يبقى انت حضرتك مش شايفه من اتجاه الحديقه بقى كده، يبقى حضرتك بس
تامر.
طيب كويس ان انا اسمع صوتك.
ربنا يخليك يا بيه. اللي انا عايز اقوله دلوقتي ان انا شايف ان الدياجنوزيس اوف هارت فيلير with preserved ejection fraction is difficult، يعني مش سهل. ليه؟ لانه we can misdiagnose a lot of people. يعني لما يجي لك واحده ست شويه اوبيز ديسنيك، وطول الوقت ديسنيك وهكذا، عشان انت تقول لي ده هارت فيلير. I think ومحتاجين زي ما الدكتور اسامه قال سكورينج سيستم واضح. How can I be sure ان دي العيان ده هارت فيلير with preserved ejection fraction؟ يعني انت اول ما تحط البروب على عيان وتلاقي الايجكشن فراكشن more than 50%، بتبقى reluctant to say this is type of heart failure. ايه رايك يا تامر؟
دكتور حازم، لو رجعنا كده في المحاضره كان في 3 مناطق كنا محتاجينهم تو كلاريفاي. اول حاجه ان احنا ريديفاين مره ثانيه العيانين بتوع البريزرفد ايجكشن فراكشن والاوفرلاب اللي بيحصل مع الميد رينج، ادي جزء. الحاجه الثانيه عايزين حاجه تبقى سكس سبيسيفيك كات اوفز لكل البارامتر، الفيميل من الميل. ده الجزء الثاني. الجزء الثالث اللي هو الهارت فيلير اللي هو ويز بريزرفد ايجكشن فراكشن دي تو سكندري كوز، واحنا مش محددينه، فبالتالي عمالين نمانج العيان او البيشنت ومش عندنا ريزولف كويس، او عندنا ميني ريكارنسز. عشان كده في سكندري كوز موجود، سواء بعض العيانين اللي عندهم اميليدوزز، some sorts of hypertrophic cardiomyopathy، تمام، دول بيبقى ليهم treatments specific للكوز which lead to الهارت فيلير with preserved ejection fraction. يبقى اول حاجه الاوفرلاب ما بين البريزرفد والميد رينج، ده لازم نعمل له ديستنكشن، نميزهم من بعض الجروبين دول. يبقى عندنا كات اوفس واضحه للفيميل والميل والسكندري كوز. الثلاث حاجات دول من الامور اللي ممكن تساعدنا كتير قوي ان احنا نقدر نعمل مور سبيسيفيكيشن للتريتمنت للهيف بيف. الريديوسد ايجكشن فراكشن واضح ان هو جروب محدد. وانس ان انا الايجكشن فراكشن قل عن 40% ابتديت اتعامل معاه بسيرتن جروبس وعليها ترايلز واضحه. اما الجروب بتاعت البريزيرفد ايجكشن فراكشن هي بقى دلوقتي الاصعب. هو يبدو خارجيا او ظاهريا اسهل، ولكن ما عنديش دراجز فيها يعني اوف شور او سيرتن او هاي ليفل اوف ايفيدنس كلاس 1 كتير. عندي بعض دراجز كونفليكتنج، حاجات بتشتغل ولا لا. يعني عندنا في الاي ار بيز دكتور اسامه بيه قال لنا انه لغايه دلوقتي معانا الكانزرتان بروفد. طب هل السؤال بقيه الاي ار بيز بروفد ايضا ولا لا؟ اسبرونولاكتون مش قادرين الترايلز الجديده بيعملوا تاني بيشوفوا القصه هتقدر تطبق عليها زيها زي الريديوسد. هو بروفد في الريديوسد ودخل جايد لاينز تمام. فما بقاش عندنا برضه الديفينيت دراجز واضحه زي الريديوسد. يعني كل الاهتمام والخوف كان من الريديوسد، فبقى الريديوسد اسهل في التشخيص واسهل في العلاج. انما ستيل البريزيرفد دلوقتي بقى مور كونفيوزنج وعايز يتميز اكتر، وعايز كمان مور ترايلز تقدر تحدد which drugs to be proved. عندنا كذا دراجز ما ثبتتش، سلدنافيل، ايفابرادين، الايزوزوربيت مونونايتريتس، كل ده ما ثبتش انه في سبورت نو بنفيت. وعندنا كونفليكتنج ريزلتس من بعض الدراجز، وعندنا يعني دراجز هتشتغل على كذا ليفل تاني، ميتوكوندريال اس سي جي اوكي، بس لسه برضه مش عندنا بروف منها. فبالتالي اصبحت مور ديفيكولت اند مور جراي المنطقه بتاعت الهيف بيف.
دكتور اسامه بيه، كنت زمان لما اجي اقول محاضرات كتير عن الدايستوليك هارت فيلير، وكان جمله شهيره قوي ان الليفت اتريال انلارجمنت عباره عن كورنر ستون في تشخيص الدايستوليك هارت فيلير. زي كنا دايما تقول جمله كده برونولد لايك هيموجلوبين A1C فور دي دايابيتس. هل still left atrial size have any implication عن تشخيص الهارت فيلير with preserved ejection fraction؟
A very good, interesting questions. First, we define heart failure as a clinical syndrome from the clinical symptom of the patient. However, the clinical sign in case of HFpEF, gallobarism, not present. Ejection fraction as echocardiographic, not present. However, diastolic dysfunction, as you have seen, that left atrial enlargement is a diagnostic tool. It's the most important and specific diagnostic tool. And diastolic dysfunction is an essential for the diagnosis of HFpEF. Guidelines reported that apart from elevated natriuretic peptide in case of HFpEF, one from two finding must be present. First, the diastolic heart failure or structural or functional cardiac disease. So the left atrial enlargement is essential and important in case of HFpEF. However, one may ask that, and if it is not present, left atrial enlargement, and still the patient complaining, it is heart failure. It is not heart failure. There is no clear answer. But it is a left atrial enlargement is definite, a clear finding in diastolic dysfunction. And some reported also, as you have said, left atrial enlargement again is must. It is a must and clear evidence, or one of the most important diagnostic parameter for HFpEF. However, I know that in case of heart failure with reduced ejection fraction, you must give some drugs that improve the cardiac function, myocardial function. And as all definition is inability for the heart to pump sufficient blood. And here, is it a disease in the myocardial disease? is not known. It is associated condition lead to, however, maybe heart failure with preserved structure without associated condition, apart from obesity.
Okay. Tamer, in this era of confusion about the diagnosis, can a new modality of images like MRI heart, if we did for those patients with preserved ejection fraction, MRI for the myocardium, may make some difference for the orientation of the cells, for the matter of the fibrosis inside this myocardium without affecting the function?
أنا مستني السؤال ده دكتور حازم. يعني أنا مستنيه بصراحة. أنا عايز أبتدي بقى من أول فين؟ من أول الإيكو. لما إحنا بنشتغل ده الكونفشنال إيكو، إنما التيشو دوبلر إن إحنا نشوف الإي أوفر إي داش ريشيو، إن إحنا نشوف اللونجيتيودنال ستريم باترن اللي بنشوفه في الإيكو، ده هيحسن الدايجنوزس بتاعنا. الجزء الثاني if we suspect that there is a myocardial disease، طبعا الام ار اي من الحاجات اللي بتعمل تيشو سبيسيفيكيشن لميني دايجنوزز، خاصه اللي هم السب كلينيكال. يعني بعض الفورمز بتيجي من الهارت فيلير نوت اتيبيكال فورم، يعني لو شفنا الامايليدوزز في التيبيكال فورم هنشخصه بسهوله، ولكن كتير قوي بتيجي باتيبيكال فورمز وكتير قوي بتيجي بسب كلينيكال فورمز. التيشو كاركترايزيشن من الام ار اي فور اكزامبل هيبقى فيري هيلبفول تول، لان وانس ان انا شخصت الكرايتيريا بتاعت المايكارديوم والبروبر الموجود هقدر ادايركت الثيرابي في الاتجاه دون. والمور اكيوريت دايجنوزس باستخدام البارامترز بعد الكونفنشنال اللي بنستخدمها في الايكو it will add more for diagnosis. يبقى الدايجنوزس هيبقى مور بيتر، هنقدر نعمل مور فولو اب ونقدر نحدد بروجنوز كويس. والتيشو سبيسيفيكيشن لايك الام ار اي help us في الدايجنوزس اوف سم تايبس اللي هم undiagnosed وشايفينها انها الكونفنشنال كل حاجه نورمال طبيعيه، فبنقول دون دايستوليك هارت فيلير، والعيان بيجي له ريكارنت هارت فيلير وفي underlying cause not diagnosed. الام ار اي may be a tool very important tool لانه عنده قدرات عاليه جدا ان هو يعمل تيشو سبيسيفيكيشن، وهيبقى one of the more tools will be used more and more in the future.
دكتور حازم معلش كنت عايز بس اسال اول حاجه عن الدكتور تامر وعايز برضه اعرف رايك. يعني انت you have mentioned that cardiac amyloidosis it is a specific type of heart failure amyloidosis.
Yes.
But that the distinction or the arrangement in the myocardium and the deposition of amyloid tissue in the heart not present on all patients with heart failure with is a specific entity of heart failure. Yes. Second, maybe a cause for heart failure of with preserved, but it is not actually is the all heart failure with ejection fraction with preserved. Second, can you actually prevent deterioration of heart failure with preserved ejection fraction from deterioration and going downhill to heart failure with reduced ejection fraction through mid-range?
Yeah, if we have a definite cause, I think we can. If we haven't,
up till now, what is the causes? Hypertension, obesity, ischemia, smoker, whatever, cardiovascular, non-cardiovascular. It is a cause or associated condition with heart failure.
يعني can be
hypertension. When hypertension causes hypertensive cardiomyopathy, chronic kidney disease, adrenal heart failures, diabetic cardiomyopathy, obesity may be overloading heart. Is all have the same mechanism in the development of heart failure, or it is associated condition that must be treated to improve the clinical manifestation of heart failure reduced ejection? After I know you have give your answer, I want to know the Dr. Hazem opinion.
Dr. Hazem معانا؟
I think يعني it's a very good question, but we know from the causes of heart failure, all what you said can cause by per se a heart failure. So we cannot differentiate between the associated comorbidities and the causes of heart failure, because all of these ischemic heart disease, hypertension, obesity, metabolic syndromes, at the end can cause all types of heart failure. And you need to say this is just associated disease, just comorbidities for the heart failure. But we know from the literature, there are causes, definite causes for heart failure, because all of these diseases end by heart failure.
And one of the most important mechanism is to control all of these factors, because if we cannot control hypertension, if the hemoglobin 1C, for example, is out of control, as there is more myocardial ischemia, I think there is more precipitation of heart failure. So to control heart failure per se, we should control these risk factors and treat the heart failure. So they are combined to have the good results. دكتور حازم اختفى.
No, see, I have a problem in my
okay, بس هو
my Zoom. Yes, I am here.
Okay. Dr. Tamer, you don't answer my question.
Yeah.
Can you prevent the deterioration of heart failure with preserved ejection fraction from downhill to mid-range and reduced?
If there's a definite cause or causes for this heart failure, and we control these causes, I think we can prevent this type of heart failure to deteriorate to mid-range or reduced. If we define the cause of heart failure and well treated and well managed, I think we can prevent.
I hear you very well, but I have a problem with the video. So I leave Dr. Osama to give the final comment for this meeting, please.
Thanks, Dr. Hazem, Dr. Tamer. Definite, there is a category of heart failure with preserved ejection fraction, which is not uncommon, present. And this category of patient with clinical manifestation of heart failure must be screened well for non-cardiovascular and cardiovascular comorbidity that must be well identified, well assessed, and the patient must be stratified according to these comorbidities, whether cardiovascular or not cardiovascular, and must be treated in the way which must be safe for this particular patient to alleviate symptoms and prevent deterioration of this patient to more worse condition, which is heart failure with reduced ejection fraction.
Okay, so from this webinar, the heart failure with preserved ejection fraction is difficult entity for diagnosis and for management until now. We must, because it is a clinical syndrome, we must review the clinical history and the clinical examination for our patient very well. I think controlling the comorbidities of our patient, number one, to relieve the symptoms, and number two, to decrease the hospitalization for heart failure with preserved ejection fraction is very important. Still, until now, there is no specific therapy except the diuretic to relieve the congestion. At the end, I'd like to thank Professor Osama Sanad, Professor Tamer Mustafa, my dear brothers and colleagues. Also, I'd like to thank Novartis Company and Icon Company, and best wishes for all attend this meeting. Be safe in this era of COVID-19. We pray for our country and for the health of all our people. Thank you very much. See you in the near future. Thank you very much.